Pelvic organ prolapse. Definition: displacement of genital organs beyond their normal site. Genital prolapse, vertical downward displacement. Incidence, 5 to 10%, varies with healthcare standards, less common in Black and Asian women. This condition involves the descent of pelvic organs, impacting quality of life. Etiology. Pelvic organ prolapse is defined as symptomatic descent of one or more of the anterior vaginal wall, the posterior vaginal wall, the cervix, or uterus, or the apex of the vagina, vault or cuff. Etiology of genital prolapse. Weakness of pelvic supports. Congenital factors. Connective tissue weakness, split pelvis, spina bifida, collagen disorders. Acquired factors, childbirth trauma. Menopause, estrogen deficiency. Precipitating factors. Increased intra-abdominal pressure, COPD, constipation, heavy lifting. Traction on uterus, cervical polyps, fibroids. Types of genital prolapse. Vaginal wall prolapse. Anterior, cystocele, urethrocoele, cystourethrocoele. Posterior, enterocele, rectocele. Vaginal vault prolapse, post-hysterectomy. Uterine prolapse, first, second, third degree. Combined prolapse, uterovaginal vs vaginouterine. Degrees of uterine prolapse. First degree, cervix below ischial spine, not through vulva. Second degree, cervix plus uterine body through vulva. Third degree, complete uterus outside vulva, procedentia. Clinical examination. For women referred to secondary care for an unrelated condition who have incidental symptoms or an incidental finding of vaginal prolapse, consider referral to a clinician with expertise in prolapse. For women who are referred for specialist evaluation of vaginal prolapse, perform an examination to assess and record the presence and degree of prolapse of the anterior, central, and posterior vaginal compartments of the pelvic floor, using the POP-Q, pelvic organ prolapse quantification, system. Assess the activity of the pelvic floor muscles. Assess for thinning, drying, or inflammation of the vaginal walls, loss of elasticity affecting the vaginal muscles and shortening of the vagina. Rule out a pelvic mass or other pathology. The POP-Q system, pelvic organ prolapse quantification, is a standardized method used by healthcare providers to measure and describe the severity of pelvic organ prolapse, POP. It's considered the gold standard because it's objective, reliable, and reproducible. Purpose: quantify how much the pelvic organs, like the bladder, uterus, or rectum, are descending into or outside the vagina. How it's done: specific points inside the vagina are measured in centimeters relative to the hymen, the reference point. Measurements: 6 points are assessed: A, BA, C, D, AP, BP, plus the genital hiatus, GH, perineal body, PB, and total vaginal length, TVL. The measurement parameters are made up of 6 distinct locations: A, BA, C, D, AP, BP. Point A is at the midline of anterior vaginal wall. Where no prolapse is present, this location is 3 centimeters up from the hymen, merely interior to the vaginal opening. Parameters from the hymen can be -3 cm indicating no anterior vaginal prolapse or +3 centimeters, which is a full prolapse. Point BA refers to the most distal portion of the remaining upper anterior side of the vaginal wall. This location coexists with A-3 cm in a woman with no anterior prolapse. However, in a woman with full prolapse, this location coexists with point C. Its location can range from -3 to +6 or +7 in severe cases. Point C is the lowest edge of the cervix or the vaginal cuff, i.e. hysterectomy scar. This location identifies if the cervix is descending. Point D is the topmost point of the posterior vaginal wall. This location can be contrasted with point C to assess if the entry to the cervix has been extended. Point AP is located midline of posterior vaginal wall 3 cm proximal to hymen. The parameters for this point can range from -3 cm to +3 cm relative to hymen. Point BP refers to the most distal portion of the remaining upper posterior side of the vaginal wall. Its location can range from -3 to +6 or +7 in severe cases. GH is the genital hiatus that records the length from the urethral opening to the posterior vaginal opening/hymen. The hiatus refers to the opening in puborectalis muscle, a component of the levator ani muscle group. A larger distance here may indicate laxity in this area. PB is the perineal body and is recorded from the posterior aspect of hymen to the mid-anal opening. This will give an insight to the tonicity of superficial pelvic floor. Through vaginal birth, the perineal body can be injuried via tears or by an episiotomy. TVL refers to total vaginal length measured from hymen to the most distal point. Knowing this allows the depth of prolapse to be assessed and reassessed post-surgical repair. Stage 0, no prolapse is observed. Points A, BA, C, D, AP, and BP are all /=-3 cm. Stage 1, the most proximal portion of prolapse is greater than 1 cm above the level of the hymen. Points A, BA, C, D, AP, and BP are all -1 cm. Stage 2, the most proximal portion of prolapse is found between 1 cm higher than hymen and 1 cm beneath hymen. Points A, BA, C, D, AP, and BP can set at -1 cm and +1 cm. Stage 3, the most distal part of the prolapse extends more than 1 cm beneath the hymen but no further than 2 cm, resulting in no measurement larger than TVL. Points A, BA, C, D, AP, and BP can be /=+2 cm and /=TVL-3 cm. Stage 4, vaginal eversion has taken place or eversion to with 2 cm of TVL. Points A, BA, C, D, AP, and BP can be /=TVL-2 cm. Comprehensive clinical assessment of vaginal prolapse. Examination objectives. Assess and record anterior, central, and posterior vaginal compartments using POPQ for standardized staging. Pelvic floor muscle and vaginal health. Evaluate muscle activity, vaginal wall integrity, elasticity, and length. Exclude masses or other pathologies. This thorough evaluation optimizes diagnostic accuracy and informs individualized management plans based on severity and Clinical symptoms of genital prolapse. Mass, a vaginal bulge or sensation of something coming down. Lump in vagina, vaginal wall prolapse, or protruding cervix, uterine prolapse. Pain, low backache, heaviness, dragging, suprapubic discomfort. Discharge/sexual issues, decubitus ulcer, dyspareunia, lack of satisfaction. Urinary and rectal symptoms. Urinary, stress, incontinence, voiding difficulty, incomplete emptying, frequency UTIs, cystitis, stones. Rectal, constipation, incomplete emptying, piles from straining. Precipitating symptoms. Chronic constipation, cough, abdominal enlargement, carrying heavy objects. Old woman. Menopausal symptoms. Assess how far these symptoms affect women's quality of life. Physical examination. General/abdominal. Detect comorbidities, obese, chronic obstructive airway disease. Abdominal swelling, ascites. Local, vulva/vagina. Identify prolapse type and degree. Check for perineal tears, ulcers. Bimanual, uterus/adnexus/Douglas pouch. Normal rectocele and cystocele. Picture showing enterocele, the other uterovaginal prolapse. Differential diagnosis. Anterior wall, cystocele vs Gartner's cyst. Urethrocoele versus diverticulum. Posterior wall, rectocele versus dermoid cyst. Enterocele, gurgling, impulse on cough. Differential diagnosis in case of uterine prolapse. Uterine prolapse versus other conditions. True prolapse, older, multiparous, cervix outside vulva. Congenital elongation, young, deep vaginal fornices, no descent. Differential diagnosis from other masses, polyps, fibroid, carcinoma, uterine inversion. Investigation. For women with pelvic organ prolapse, consider using a validated pelvic floor symptom questionnaire to aid assessment and decision making. Do not routinely perform imaging to document the presence of vaginal prolapse if a prolapse is detected by physical examination. If the woman has symptoms of prolapse that are not explained by findings from a physical examination, consider repeating the examination with the woman standing or squatting, or at a different time. Investigation. Consider investigating the following symptoms in women with pelvic organ prolapse. Urinary symptoms that are bothersome and for which surgical intervention is an option. Symptoms of obstructed defecation or fecal incontinence. Pain. Symptoms that are not explained by examination findings. Imaging and symptom correlation in prolapse diagnosis. Routine imaging is not recommended if prolapse is evident on physical exam. Repeat examination. Consider re-examination standing or squatting if symptoms are unexplained by initial findings. Symptom investigation. Bothersome urinary symptoms potentially warranting surgery. Defecatory dysfunction and fecal incontinence assessment. Unexplained pain or symptoms beyond clinical exam findings. Photographs in lithotomy position and sagittal magnetic resonance imaging showing vaginal wall prolapse. Prolapse might include top to bottom anterior wall, vaginal apex, or posterior wall. Color codes include purple, bladder, orange, vagina, brown, colon and rectum, and green, peritoneum. Prophylactic measures. Good obstetric care. Avoid straining, heavy lifting, smoking. Proper management of chronic obstructive airways disease. Postnatal, pelvic floor exercises. Vaginal vault support post-hysterectomy. Management of prolapse. Non-surgical treatment for anterior vaginal wall prolapse. Discuss management options with women who have pelvic organ prolapse, including no treatment, non-surgical treatment, and surgical options, taking into account the woman's preferences, site of prolapse, lifestyle factors, comorbidities, including cognitive or physical impairments, age, desire for childbearing, previous abdominal or pelvic floor surgery, benefits and risks of individual procedures. Consider a program of supervised pelvic floor muscle training for at least 16 weeks as a first option for women with symptomatic POPQ, pelvic organ prolapse quantification, stage 1 or stage 2 pelvic organ prolapse. If the program is beneficial, advise women to continue pelvic floor muscle training afterwards. Management of prolapse. Non-surgical treatment. Consider giving advice on lifestyle to women with pelvic organ prolapse, including information on losing weight, if the woman has a body mass index greater than 30 kilograms per square meter. Minimizing heavy lifting. Preventing or treating constipation. Consider vaginal oestrogen for women with pelvic organ prolapse and genitourinary symptoms and signs associated with menopause. Consider a vaginal pessary for women with symptomatic pelvic organ prolapse, alone or in conjunction with supervised pelvic floor muscle training. Patient-centered non-surgical management strategies. Individualized considerations. Management includes no treatment, conservative measures, or surgery based on patient preferences, site of prolapse, comorbidities, age, and reproductive desires. Lifestyle modifications. Weight reduction when BMI greater than 30 kg/m2. Minimizing heavy lifting. Preventing or treating constipation. Collaborative discussions empower women to make informed choices aligned with their lifestyle and overall health status. Adjunct therapies and conservative treatment modalities. These approaches aim to relieve symptoms, improve muscle support, and maintain vaginal health, offering effective non-surgical options. Pelvic floor muscle training and pessaries. Supervised pelvic floor exercise program for greater than or equal to 16 weeks as first-line treatment for mild to moderate prolapse. Pelvic floor/Kegel exercises are designed to strengthen the pelvic floor muscles. Squeeze muscles as if trying not to pass gas or stopping the flow of urine. Hold the squeeze for 3 seconds, then relax for 5 to 10 seconds. Start with 3 seconds and gradually increase squeeze time to 10 seconds. Repeat the exercise 10 times per session. Goal: prevent progression, relieve mild symptoms. Topical estrogen. Recommended for menopausal women with genitourinary symptoms, estrogen-releasing rings assist those with physical/cognitive limitations. Pessary use alone or with muscle training, with care guidance and periodic assessment every 6 months. Ring pessary in situ. Use of a pessary may be limited in patients with dementia or pelvic pain. Women with decreased dexterity may require office management of pessaries. These devices should not be placed in patients who are unlikely to adhere to instructions for care or follow-up because serious complications such as erosion into the bladder or rectum can result from pessary neglect. Some common pessaries. First row, left to right ring, ring with support, and incontinence ring. Second row, donut, Smith-Hodge, and gel horn. Third row, gerung, cube, and inflatable. Surgical management, balancing benefits and concerns. Indications for surgery. Offer surgery to women with persistent symptoms, unresponsive or unwilling to try non-surgical treatment. Informed decision making. Use decision aids covering treatment options, risks, benefits, recurrence rates, and anesthesia differences to support shared decision-making. Vigilance around mesh use is necessary due to uncertain long-term safety. Transparent discussion about potential outcomes is essential. 2. Surgical treatment. Individualized treatment plans. Informed decision-making with the patient. Consideration of the woman's specific condition and preferences. The role of the multidisciplinary team, especially in complex cases and when mesh is being considered. Key points include: surgical options should be discussed with the woman, considering her individual circumstances. The guideline emphasizes the importance of a regional multidisciplinary team in cases involving vaginal mesh for prolapse. It also stresses the importance of recording details of procedures and any complications in a national registry. Preoperative preparations. Abdominal and local considerations. Thorough preoperative preparation is crucial for successful surgical outcomes. This includes both abdominal and local considerations. Bowel preparation may be necessary, along with careful antiseptic cleaning of the surgical site. Patient education and counseling are also vital components of the preparation process. Surgical treatment for anterior vaginal wall prolapse. 1. Anterior colporrhaphy, anterior repair cystocele or cystourethrocoele without stress incontinence. 2. Anterior colporrhaphy with Kelly's suture, indicated in cystocele or cystourethrocoele with stress incontinence. Posterior vaginal wall prolapse. Posterior colporrhaphy, posterior repair. Indications for posterior repair: symptomatic rectocele, incomplete rectal evacuation or evacuation that need digital manipulation or splinting to aid evacuation, or slackness at intercourse. Posterior colpoperineuraphy may be coupled with placement of a mesh between the vagina and rectum to support the rectovaginal fascia. Mesh use in prolapse surgery, safety and documentation. Patient counseling. Explain mesh type, permanent versus temporary, and potential outcomes transparently. Documentation. Procedures and outcomes must be recorded in a national registry for monitoring safety and effectiveness. Written information. Provide patients with implant details such as device name, manufacturer, insertion date, and surgeon contact. Advanced surgical choices for uterine prolapse. Uterus preserving surgery. Options include sacrospinous hysteropexy and Manchester repair, particularly for women desiring future childbirth. Mesh-based procedures include abdominal or laparoscopic sacrohysteropexy with mesh. Careful patient selection and counseling advised. These procedures expands surgical choices, balancing anatomical correction with patient values and safety considerations. The Leffert operation, also known as colpoclesis, is a surgical option for women with severe prolapse who are no longer sexually active. It involves partial or complete closure of the vagina to provide support. This procedure is effective in alleviating symptoms and improving quality of life. Surgical approach for enterocele repair, reduction of hernial content and excision of hernial sac. A primary step in surgical repair involves carefully reducing the hernial content, returning the prolapsed organs to their anatomical position. The hernial sac, the weakened tissue that allowed the prolapse, is then meticulously excised to prevent recurrence. This step is vital for long-term success. Uterosacral ligament suturing, closing the hernial orifice. Reinforcing the uterosacral ligaments is a key component of prolapse repair. Suturing these ligaments helps to close the hernial orifice, providing strong support to the pelvic organs. This technique restores the natural anatomical structure and prevents future prolapse by strengthening the pelvic floor. Surgery for valve prolapse, options and considerations. Discussion and decision making. Engage women in discussion of non-surgical and surgical options using decision aids to promote informed consent. Surgical choices. Vaginal sacrospinous fixation with sutures. Abdominal or laparoscopic sacrocolpopexy with mesh. Registry and documentation. All mesh insertions require detailed documentation and registry reporting for safety monitoring and quality assurance. Thorough patient education and careful surgical planning optimize outcomes for valve prolapse management. Addressing recurrent prolapse. Management strategies. Recurrent prolapse presents a challenge, requiring careful evaluation to determine the underlying causes. Management strategies may include revision surgery, utilize different surgical techniques, or consider alternative approaches like mesh augmentation. A thorough understanding of previous procedures is essential. Conclusion: summary of surgical techniques for genital prolapse repair. Surgical management of genital prolapse encompasses a range of techniques tailored to individual patient needs. From hernial sac excision to ligament reinforcement and specialized procedures like the Leffert operation, surgeons have multiple options for restoring pelvic support and improving patient outcomes.